Hello, is that Marty?
No, it's Maurice.
Ah, Maurice, how are you?
So, we hear you well and we see you well, so the stage is yours. We're joined by many of our friends and colleagues from all over the world who will be listening and hearing to what you have to present, so please go ahead.
So you've got to listen to my horrible Australian accent for 10 or 15 minutes. So. Anyway, so this is a very interesting case, and we'll hear all about it shortly. I'd like to first introduce my colleague and friend, Dr. Wu, and also Dr. Park, who are going to be assisting me, and the wonderful team here, and Dr. Kang over there, who's running the intravascular ultrasound for us. In short, it's a left main lesion with an LAD diagonal bifurcation very close to the left main origin. So we're going to do a 3-wire technique. Perhaps you'd just like to describe
let
the
me
case.
introduce the patient history. And this patient is a 58-year-old male and presented with a stable angina for 1 month ago. And in outpatient clinic, and we checked the coronary CT, and coronary CT angiography shows significant stenosis in distal left main and prox LAD. And patient history and hypertension and hyperlipidemia and ex-smoker. And the echocardiography was normal, and we did not check the treadmill and thallium scan. And we checked the FFR at first coronary angiogram, and the FFR was baseline was 0.92. After adenosine is down to 0.67. Syntax score is 14.
Okay, so Maurice, do you want to make any comments about this?
No, I mean, I think maybe you should start telling us what strategy you're thinking about. Marty just joined us now. He's a little short of breath, so we're going to let him...
He might need an angiogram.
Yeah.
Okay.
So go ahead, please.
How about just showing the baseline angiogram?
Yeah, we'll start by showing the baseline angiogram so that you can see the case. I mean, you've just had a sneak preview of the images. So let's show the baseline angiogram if we can.
Yeah, we see it.
Spider view.
So
Area color view.
So there's the lesion. You can see that it's a proximal ostial LAD lesion, and on IVUS we'll see shortly it extends back into the left main. Left main's big. Circumflex is a large territory with a large LV supply and has a very healthy origin, and you'll see shortly. Now in the AP caudal view you see there is an obscured diagonal there, and many other views we've looked at, but you can only really see the origin of the diagonal into the LAD in an LAO caudal. So we'll show you that.
Where was the FFR? I'm sorry.
So the FFR was done into the LAD, Maurice. So, and that was 0.67 or 0.69? 0.67. So there's no FFR done into the diagonal, and you can see the diagonal there. Really, the other shots don't provide any information. There is some narrowing at the ostium of the diagonal, and we've decided to protect that with a wire. Circumflex a big territory, but the right is dominant, and the diagonal is certainly worth protecting. So at the moment we have 3 wires in. We have a wire down the LAD, a wire into that narrow angle proximal large diagonal with a short discrete ostial narrowing. We haven't assessed that by FFR or by IVUS. And you see the other wire is into the large circumflex, which does have a very distal, healthy LV supply.
And this is an 8 French guide?
It is an 8 French guide, that's correct.
And it's a Judkins guide, is that correct?
It is a Judkins guide, Marty, that's right. So now normally this case I would sort of do by a radial approach, but this man has had a radial angiogram from the right side just a month ago, and given that we thought that there's a possibility that we might need a mini culotte or something if we interfere in any way with the ostium of the diagonal, we just allowed ourselves a larger guide. And if we were doing 7, and we could do 8 pretty easily. He's otherwise well, vasculature good.
Yeah.
So before you got on, we had a whole hour of the results from the perfect trial and the cross trial regarding bifurcation. so it is very timely. So you can go tell us a little bit about the strategy for the bifurcation itself of the diagonal, and then we'll talk about the LED if you don't mind.
Okay.
Maurice, maybe we can, before we do a strategy, maybe IVUS would need anything making a strategy choice.
I agree.
So that the Ken can show the IVUS was.
Beautiful.
Yeah, I think the IVUS would be very helpful. And
Okay.
I'm not even sure how to characterize this by Medina class, that bifurcation. At least in this caudal view, it looks like there's some narrowing at the origin of the diag. So.
Correct, there is, Marty.
Yes.
And whenever you have osteal LAD disease, it's always important to note that it's extremely unlikely that you won't have some distal left main disease as well. And there is a small intermediate branch, which is not, a vessel that you would want to stent, but you wouldn't want to lose it either.
No, absolutely. We completely agree with that strategy. And in fact, actually, what you've just said, Marty, is absolutely true on the IVUS. And Dr. Kang will show you that the plaque in the left main runs along the roof of the left main, the LAD superiorly back into the left main, beyond the origin of the circumflex. So it is not something we could deal with by a simple osteal technique. Dr. Kang, do you want to run the IVUS? This is LAD.
Let's get started here. Here is mid-LAD. It's below the diagonal branch lesion. And you can see the diffuse eccentric small plaque, but lumen area is very large. And maybe here is the distal landing site, and you can see the less than 40% of the plaque burden and large lumen area. Here, the vessel size is more than 4 millimeter, and lumen size is approximately 3 millimeter. And here, it's the measurement. Then move to near the diagonal branch. You can see the diagonal branch opening here, and you can see only media. So there is no plaque, and I think it's a large lumen area, so it's safe to be crossed over. And then here is the considerable amount of plaque, and you can see some lipid core, ecolucent area. It reflects the vulnerability of the plaque. So the eccentric large plaque is here, and you can see the LAD osteum, the very osteum part, and also we can measure the minimal lumen area here. So
I think you made a good point. There's tremendous heterogeneity in the echogenicity of that lesion. This is what I would characterize as more of an angry plaque. If you did a lipid scan, I'm guessing you would see some yellow.
yes,
Yeah, that's
I
right.
think so.
It's a very soft, unhappy looking thing, isn't it?
Ecolucent area is here and here, and the lumen area, minimal lumen area was 2.8 square millimeter at the LAD osteum. Then you can see there is circumflex coming into the left main. But if you look at the 6 o'clock view, you can see the huge circumflex without any disease. But we can make sure that by circumflex pullback IVUS. Then you can see the distal left main side here. It shows some plaque, but the lumen area is very good. But if you want to see the normal looking area here, it may be the proximal landing site. The vessel size is 4.7 millimeter, and the lumen size is 4.3 millimeter.
So by criteria of vessel sizing and the lumen, as we saw it here, do you think, Marty, still you keep the fact that treatment has to involve the left main, or maybe not?
Well, I don't think the left main is significantly diseased. I think there's plaque extension to the left main, but it's such an osteal lesion, at least we found it's easier to cross over to the left main under those circumstances. I think there's a size disparity, which is not trivial, because this left main is at least 4.5. It's a 4.55 vessel. So if you cross over, you have to take that into consideration.
So,
what is,
we
so
completely agree with those suggestions, Marty. And what we think is that we're going to try and deploy a single stent, cross over into the left main, and then post-dilate the proximal part of the stent in a proximal optimization technique. The problem is here the plaque is relatively soft, and the angle into the diagonal is relatively narrow. And so I don't want to create an injury at in the LAD at the diagonal end with a very large stent. So it'd be easier to use a compromise technique where we have decent stent for the LAD beyond the diagonal and for the proximal LAD, and then use a proximal optimization technique for that same stent in the left main. But I think you have to cross over.
What about the diagonal?
Well, the diagonal we're just going to protect with a wire. It's a very short, discrete lesion. There's no reason why we should actually pre-dilate that. And you could see from Dr. Kang's lovely IVUS images, there was no significant plaque at the ostium. So I'm concerned about the risk of carina shift here if we overdo it. So we're going to do a direct stenting technique. The plaque is pretty soft, only tiny little bits of speckled calcification there in the proximal LAD. So I think that a direct stent technique will work, and we're going to leave enough room to do a pot technique in the left main.
And could I show you the
Is
circumflex?
LAD left main pullback enough, Ian, or would you consider doing IVUS into the circ?
We have done IVUS into the circ, and actually we could actually show that if you wish. We've got a very nice circ image. The cross-sectional area at the orifice of the circumflex.
8.6 square millimeter and
So-
no plaque.
You could drive a small Kenworth truck into the circumflex there from the left main. So I don't really think there's going to be an issue. Generally, anything over 5 square millimetres at the ostium is fine for me, and I know others actually will use even smaller dimensions of the ostium of the circumflex in a crossover technique. I like to see about 5 to be sure.
Especially, I would like to kind of discuss with you, especially with this type of osteal disease at the LAD and no disease in the circumflex. Maybe indeed, as was suggested by yourself, Marty, and everybody here, that getting back into the left main also can safeguard from this plaque shift into the circumflex if you try to be very cute and stop it at the origin, the stent.
Yeah.
So crossing over also has another advantage, is that it may leave the architecture of the circumflex better safeguarded.
Also, if you don't place the stent in the left main, you essentially invariably miss the ostium of the LAD. So it's simply not feasible with the technology that we have.
No, that's absolutely a fantastic point. And the safest thing here really is to cross back. And if you can see the longitudinal image of the IVUS in the top screen, you can see very clearly the green marker there showing the plaque extending well back beyond the ostium. So Dr. Kang is showing us that now nicely. There's the plaque, and we're coming across the circumflex origin now, and you can see the plaque is continuing back. Keep coming back, actually, Dr. Kang. You can see there's pretty tidy plaque going back across that circumflex ostium. So I think it's going to be hard to exactly get that right, and it's safer to just cross over.
So you're going to size the stent to the LAD reference beyond the diagonal?
Yes, that's right, we are, Marty. So what we've taken is a 3.5 Promus Premier 20 millimetre stent. We know that distance, you can see there, is 20 millimetres to a safe landing zone in the LAD beyond the diagonal. And we're just going to try a direct stenting technique. Don't worry about the guide, it'll be okay. It's a nice straight run. So the guide's not in far, but it'll be fine. And so, I'll just push him up now there. Yeah, that'll be all right. So, and you notice we've kept the distal end of all 3 wires from buckling in case we need to exchange those. So in these techniques where you do wire exchanges in these procedures, I like to try and keep the wires from not buckling. Now, just hang on a second. No, wait. Let me pull the guide back a bit. So I'll just go a wee bit further. Right, just test there for me.
So another point is, do you stop in the middle of the left main, or would you try to go back all the way to the origin?
I think it's we don't need to go all the way back because the vessel is not diseased, and so I think we'll get a good result here. Just let's move forward a bit. Tiny test again, just a little test for me.
I think that's fine.
Hey,
This left main also tends to be a little bit cone-shaped, so when you get towards the ostium, it's a 5-0 vessel.
Yeah, that's
so
right.
I think the way Ian has it is perfect.
Right,
We
okay.
also underestimate a little bit where the circumflex really starts angiographically, because you see where the wire starts to split, at least
That's right.
in the funnel of the left main trunk, so it's perfect.
Yeah, I'll just pull back. Now, I'm not too concerned about trapping the wires here, so we'll only go to 12 atmospheres here. You ready? We've just pulled back inside the stent. Now this is 3.5, so it's bigger than the lumen, but right for the vessel size distally. That's 12?
12.
Come down.
Okay.
That's great. Now I'll just have a look with that. So patient's perfectly hemodynamically stable, blood pressure and ECG look pretty good, so no problems there. So
I have to say, I like the radiopacity of this stent. I think that the platinum chromium is just a little bit more radiopaque, so it just lets you see it a little bit better.
it does in these situations, and I sort of do like it. I mean, obviously there's the concern of axial lateral compression, but in this era where the promus premier, where the proximal end has been reinforced, it's really not a problem. And I think the other thing is if you approach the proximal end of even the promus element stent carefully, it's really not a problem. So let's actually, I'll push it in. I'll do. Yep, that's a bit too far. Oh, you're right on the stent. Hang on. That's too far. Right, now what I'd like you to do is give me half a second to see the stent before you put the contrast in. You ready? So wait for a second, see the stent. Beautiful, go. Okay, great. So you don't want to push the guide in too far and compress on the stent. So now we've got a little bit of jailing at the ostium of that diagonal, but the circ is looking pretty tidy indeed. So I think what we'll do is we'll cross into the diagonal. We make a decision as to whether we want to do anything for it. But I think let's, before we do anything, sorry? No. Let's actually, to choose the balloon size, what we ought to do now is run the IVUS back down, have a little look, and then we can decide where we need to start our proximal optimization technique.
So you think that the diagonal changed much after this?
Yep, that has, but there's good flow there, and this is a very narrow angle. It's a discrete lesion, good flow, no dissection. We'll have a look in other views. But the thing what we want to do here, Maurice, is actually do no harm if we can possibly get away with it. Now, if we need to do a balloon dilatation there, we can. Of course, we can check that with FFR2 as well. It's a very discrete lesion. And part of that will be carina shift, just knowing that the plaque volume is pretty significant.
Right, and we just heard again from the earlier cross data that final kiss, if you're not going to do anything, maybe did not add much.
Yeah,
or maybe
that's right.
Yeah, from the cross data.
Yeah, and I think there's always an argument for no harm. And we've got good flow here. There will be some carina shift, so we haven't exchanged the wires out yet, but we'll just leave those. So, Dr. Kang, do you want to give us a running report?
Have you done much FFR on those lesions to see whether it is significant or not?
We do, but our general rule, Maurice, is if it's under 5 millimetres long, I wouldn't deal with it. So big territory, lesion longer than 5 millimetres. So there's our distal end. Oh, Dr. Kang, you want to talk to it?
Started this beyond the diagonal branch because Dr. Kang is not here.
Oh, right.
So the diagonal still is not a prac shifting here. So we think that 3.5 is maximized in the LED beyond the diagonal and also proximal to the diagonal.
It's a tad
so only
small
inflating at about 10, then pull back we go 12 atmosphere. Of course, we are suggesting maybe we do part before we do a rewiring, but Ian like to do IVUS before we do anything.
Oh, well, just to determine what size we actually need.
And
So can we
actually,
just
the left
stop?
main is quite okay.
Yeah, the left main's not too bad. It was a soft plaque, and so so I'm going to take the IVUS catheter out now. So did everybody see that we ran through that? That was a 3.5 stent, and you see it's nicely opposed distally. It's a little bit undersized between the diagonal and the left main. And we can go ahead and do a little bit of optimization now, and the circumflex looks pretty good.
Okay.
So, Maurice, go ahead.
You would leave this wire in the diagonal, or you would re-centralize the wire?
Well, we can re-centralize the wire now, and I think that's a reasonable thing to do. We're not going to go that far down into the diagonal anyway. So what I'm going to do is just simply exchange the wires. I'm going to take the... Yep. So I'm going to take the circumflex wire out and run that into the diagonal. There we go. So, because the circ looks a pretty safe bet to me to get back through there. And we've got to take that one out anyway. No, I won't use the introducer.
I mean, the only argument about for doing the pot first is that if you're not opposed,
Undermined.
you obviously can get the wire underneath the
Yeah.
strut.
Yeah.
So some people would do the pot at this point before you
Yeah.
Yeah,
before
you
we
rewire
could.
the branch.
Look, if there was any problems actually getting down there, I would completely agree. I think that's,
Sure.
yeah. I mean, you're
Yeah, this
right.
is pretty straightforward.
Yeah, and you noticed on the IVUS, Marty, the apposition in the left main wasn't too bad, really.
It wasn't bad at all.
Yeah, it wasn't
I mean,
like
you
I was
could
floating in the mid. You could almost get away
I
with
think
it.
you could comfortably put in a 4.0 balloon. But
Yeah.
you're right. It wasn't swimming in that left main.
No, it wasn't. That's right. So we've got the
Ian,
wire in the
how-
diagonal, and now I'm just going to
How-
take the diagonal wire out. Sorry. There we go.
How much do you try to cross in the most proximal strut possible? Do you make any conscious effort or just wherever it goes?
Do you want the politically correct answer? Or I just do the best I can, you know.
Whichever.
Like, you know.
Correct answer versus what happens. Go
Yeah, I do the best I can. Which is,
You wanna take it out?
now hang on.
Oh, you
No.
wanna change.
Yeah, I want to make sure. Okay, now,
And usually you're happy with whatever it is.
yeah, so that's right. Now,
So-
there, now, well, we'll
Ian
see.
is putting out the diagonals and trying to
Now-
make it into the circle.
So
Yeah.
I'm going to put the wire into the circumflex, but when I pull the wire out of the diagonal, I always like to, and come proximal to the LA
yes.
in the left
In
main
the left
stent,
main stent, yeah.
I like to then take the wire down the stent again.
Take a chance of maybe outside this.
Yeah, so I'm not outside, because you see I've run back into the diagonal. So if you give me a little bit of test now, and just a tiny test there, just something, little picture. There you go, there he is. And
Maurice knows the Japanese colleague, they use the double channel microcaster to assisting side branch wiring, preventing the wire come out of the stands. Is any crusade caster in US or you see
I'll put the guy in. Go on, what were you going to say, Dr.
any experience of that?
Yeah, we do have a double
Lumen getting
microcaster.
microcaster.
It's fairly large profile, and to
tiny
be
test.
perfectly honest, it doesn't help under most circumstances. I think there are some better versions of this, both in Japan and in Europe.
And sometimes it kind of position you around across from the origin, so I'm not sure that would be that much helpful.
Now, generally, when you...
the Y tube.
Maybe needs to reshift the wire.
Yeah,
Maybe
that's-
it's not, the
That'll
primary
go.
curve is not good.
Yeah, we'll get him, don't worry.
There just may not be enough angle on that wire.
Yeah,
to
that's right.
turn it
No.
into the circumflex.
There you go.
We,
Okay.
it's
Very nice.
It's the right cell.
years of fishing, you see. You just got to be patient. If you're a trout fisherman, you know you just got to be patient. So there you go. So now that looks pretty good. Now let's, again, same deal.
Okay.
We want to just do a shot, do a shot. Wait a second to see the stents, and then
Somewhat close to the left main orifice.
yeah.
And guiding, guiding.
Yeah,
somewhat.
that's okay. I just was really only interested in the wire and not the guide.
Okay, all right, yeah.
Okay. So
try
now
it.
we're going to just post
Yeah,
post
part,
dilate
yeah.
the proximal section,
Okay,
and then we'll
all
go
right.
back with IVUS.
Okay, so now we have to, this is circumflex
That's
now?
So that's a 4.0, you said?
Yes.
Yeah, I think 4.0, but we could, if we had a 4.25, I'd be tempted to do that. But again, I want to look after the ostium of the circumflex as well. So I think it's a bit of a compromise here. I think a 4.0 8mm balloon, proximal part of the stent, will be a pretty tidy result.
Yep.
Yeah.
Okay, this is,
Yep.
this is
Okay.
everything.
So
Four
have you
by
got any
10.
suggestions, Maurice or Marty? Would you do something similar to this, or
Somewhat different?
something different?
Looks good.
Yeah.
So we're going to part optimization with a 4.0 by 10 Corys high pressure balloon.
Yeah, you could, if we had a 4.25 by 6, you could get a very nice result doing that. But what I want to do is definitely stay away from the diagonal now. That's the trick. Don't worry about the guide really. It's a straight run and we're just sitting there. And we've got 3 wires anchoring the whole system, and I don't want to trash up the proximal end of the stent, and I want the easiest ride into the left main possible. So it's pretty coaxial. It's not scary at all.
Really good.
So, there you go. Just
Alright.
gently in.
Okay, you want to try sitting in?
Right. Yep.
Try
No
sitting in.
contrast though,
Yeah, just
because
try
we can see.
sitting. Just in here. Okay, perfect.
Look, wait a minute. I'll come back, get the marker there. Okay, beautiful. All right. Now, hang on. Just do a little test for me. Are we, little test? Righto. Where are we in relation to that diagonal? We're nicely away from the diagonal, aren't we? Okay, that's good. I'll just suck the guide up a little bit. Off we go.
Okay. In front.
Yep. You're right.
Nominal.
Go 12, 14.
14.
Then go 16 there if you like.
So we are not
Yeah,
compromise
great.
the diagonal.
Okay, great. Yeah, so hopefully we haven't got the diagonal. We're on the taper of the balloon there. So I'll just
try to aim the edge of the stent. Maybe just perfect.
So Marty, in this anatomy, do you think dedicated bifurcated stents to allow now or future
Take a shot.
access to the
Take a shot.
circumflex are of any value?
To be honest, no.
Okay.
I'm not sure that you could position one perfectly in order to get an open cell right over the circumflex and do any better than what you're currently doing.
Yeah, we'll do the IVUS. So look, you see how the diagonal looks pretty good, doesn't it? And I mean, there's good flow in it, a little bit of pinching, and that's going to be partly carina shift. Honestly, I wouldn't chase that. What do you think, Marty? Or I would leave it alone personally. I think I'm happy with the way it looks. You notice how the stent has grown nicely for the left main, and we haven't compromised the circumflex at all because it's a soft plaque. And because we haven't gone aggressively with the distal end of the stent, we haven't got the diagonal in too much trouble. Do you think we'll have a look with IVUS?
I would agree with you here. Probably less is more.
Yeah. It's a good rule, isn't it?
Except one curiosity I've always had is the kind of trying to do, I'm not suggesting it, but looking at functional significance of these lesions with maybe FFR. I'm not suggesting in this particular case, but is this something that would be worthwhile?
Well, it might be, but it's a relatively, it's a moderate-sized diagonal, but it is a very short, discrete lesion. So there's our stent apposition distally. That's pretty tidy, and we've got 3.2, and you can see the origin of the diagonal down there at 6 o'clock. He looks pretty happy.
Yes, the diagonal branch is well open to the LAD, and the stent, the minimal lumen area is 7.1 square millimeter within LAD. And you can see the well-expanded stent, and there was no complication. You can see the circumflex opening. It's very good. And I will show you this side later. And then you can see the well-expanded and opposed stent strut here. It's more than 4 millimeter. And I will show you at the circumflex
Okay.
posterior side,
So
and then stop.
my personal feeling is I'm pretty happy with that. I mean, what Marty or the panel, Maurice?
To me, it looks excellent. I would agree with you.
So Ian, this is Chuck Simonton. What do you think the percent stenosis is right now, that diagonal ostium? What would you call it?
Oh, it's probably in the 40 to 50% range. But what we need to do is probably go to the cranial view and have a look at the ostium of that. But again, it's a narrow angle, Chuck, and if we try and treat this, we'll end up with some stent protrusion. T-stent technique is not going to be ideal. It'll have to be either crush or mini culotte, and that's just going to add a lot of metal to what is a very big LAD. So I won't have I'll have a pretty high threshold to trying to deal with that. But we can FFR if you're concerned. But we'll take a shot with the
Once we
wires
have
out of
the nitroglycerin, maybe after this we can give a good shot for you.
Yeah. Let's just.
See?
Yep.
Is it better to advance the diagonal wire more distally? Because to have a good angle.
Oh yes, we can certainly do that. I mean,
To my eye, it's looking better.
So there's wired distally.
I think it looks better now.
Yep.
It's wired distally in the diagonal. It's just folding over towards you. So let's have a look. You ready?
Yeah.
Okay. Beautiful. Yeah. So it's a little hazy there. Yeah.
So maybe
let's have a steep AP cranial.
Suggestion we can do the aria cranial or maybe cranial.
So we can always FFR this if you wish, but
Yeah. That's what I would do.
I'm not sure. You probably need a steep AP cranial to show
Say
this.
AP.
You know, it is
four
interesting
branch.
that I
Yeah.
just left a bifurcation stent session. And,
Further?
you know, it depends what
Cannot
part of the world you work
separate.
in.
Maybe, yeah.
If, you know, if you
Testing.
work in Paris, you do kissing balloons here. You do kissing
Cannot
balloons,
separate.
you know, literally in every crossover case. And they get excellent results.
Well, we can do that, and
What about in New York?
no, that's
In
going
New
to hide
York,
the ostium.
in a diagonal
go
that's this
cranial.
big, I probably would
AP
look at it
cranial.
by
Maybe
IVUS.
green.
Yeah.
The FFR is, it's easy to do, but because the lesion is so short,
Maybe
really,
just take a shot
it's
here.
almost
Okay.
always normal.
That's right.
Like this.
Yeah, that's right. And then the reality is length of the lesion is a critical determinant of resistance, which is something that's often overlooked.
So when you get the area corridor again,
Just leave it there for a minute. I'll just move the wire down.
But on the other hand, the IVUS in itself, if it is really a distortion of the anatomy with not much plaque,
Yeah.
that also would give you a level of uncertainty. So it's difficult. As long as TIMI-3 flow, maybe,
Yeah.
I'll leave it
So
alone.
Dr. Kang, are you here? Is she here? No, I was going to say if we could see, sometimes it's nice to look at the longitudinal reconstruction image of the diagonal, because when you see that, you can actually see how much of it is actually carina shift by the stent beyond the diagonal, and how much of it is actually osteal disease. And I think that's an important thing to help us. So where are we here? No, that's not going to help at all. See,
Sorry,
I think it's going to be
quickly become two stents for some.
No, I don't think I would consider putting a second stent in, but
No.
I think I would consider looking at it by
Yeah,
IVUS. It's a
we could
large
do that.
vessel. There was
Yeah.
a lot of plaque heterogeneity in the LAD that looked to be more unstable. It looked a little bit hazy in that last
maybe to the left.
caudal view. So
Okay, perfect.
So looking
Just
at
test that
it
for me,
with the
test.
idea of doing a final kissing balloon. is that
That'll
what
do.
you're
That'll do.
yes,
All right. Well, let's. We can see if we can get across with the IVUS and have a look at this just straight through the stent struts and just review it. So let's do that. And if we need to do a final kissing, we certainly can. The downside of kissing here is that if we get a dissection at the ostium of this vessel, then we're forced into a possibility of bifurcation stenting. And to me, it looks like a pretty good result. And the primary problem here is a nasty osteal LAD lesion, which was, in a sense, life-threatening, soft plaque, severe, and this is a secondary problem.
Ian, we're being told that we need to shift to the next lab to see Alan Young. So
right. Thank
why
you.
don't you kind of wrap up in whatever way you would like, and maybe we'll come back to you in about 10 minutes and just to get your final thoughts.
Okay, well, look, I think it's a soft plaque, concentric plaque. With these ones where you've got a significant size mismatch between the LAD and the left main, I think size the stent on the ideal position in the left main and use a proximal optimization technique. I think this is a very handy addition. And with these modern stents, all of the modern stents are just so good that it's easy to
Okay,
actually
so let's look at the
size.
IVUS before we leave. Yeah,
right there.
I mean, the IVUS is right across, so maybe we can look at it right now.
And then we'll find out.
And
So I
then
have
we'll go
a-
to Alan.
I'm sorry, I have a question, Dr. Yang, to Dr. Yang.
Yes?
What's the reason to dilate one more with the proximal part of stent when you're pulling back the native balloon? The second question, what do you think about if you use the longer stent to cover the distal part of stent? So as you can see, the distal part of stent, so plaque burden is a little bit higher. So if you use the longer stent, you cover the whole burden. So,
Well, the
it's
two
a-
questions.
it's a-
First of all, you noticed on the IVUS that the diagonal was intact and looked pretty good.
Yes.
So we'd be creating
I
a problem.
completely,
Yeah.
I
and-
completely agree, Ian. The
Yeah.
diagonal looked fine, and,
Yeah.
and what I like about that is that it's just reassuring.
Yeah, it
for
is
me to know that
reassuring.
there's literally no plaque in that diagonal.
Yeah.
The osteum looks fine. It's a relatively oval-shaped
Yeah.
osteum, which is typical. So I
Having
think
said
this
that,
is
Marty,
fine. I would do
my
nothing.
own practical view of this would be short lesion, moderate sized vessel, and the risk of ending up with a overlapping stents in the LAD is probably greater than leaving a discrete lesion here. Just to answer those two questions, I don't see the need to actually cover the more distal LAD disease of a minor degree just for the sake of covering it with a longer stent and running the risk of a higher risk of restenosis. And
So Ian, if you want to do a final angio for us, then we're going to need.
yeah, well, what we'll do is we'll take the wires out. I'm going to take all the wires out, and we'll give you a nice final shot. I'll just pull them back into the guide. Hang on a second. There you go. Now, wait. There you go. You ready? No, it's 1 second to see the stent, and then take the shot. Okay, sorry.
Okay, good.
Yeah,
Perfect.
Ready?
Yep. Okay, Sydney.
Okay, so it's pretty tidy. You can see it's a
Looks great.
it's a co-dominant lesion,
Great result.
yeah, I think leave it alone.
Okay, good.
Yep, very nice.
Okay.
So we're going to move. Thank you very, very much, and we'll get back to the other room. Maybe we can go to Alan.
Okay, thank you very much,
thank you.
everybody. Thank you.
Great work,
Thanks,
Ian.
team.
Yeah, thank you.
Hello.
Hi, Alan.
Hello, Alan.
Hi, Marty. Hi, Maurice and the panelists. We have an interesting case that Dr. Asan from Thailand is going to present to us, and also on my right is Dr. Jang from Asan Medical Center. So we have a great team. We have a pretty interesting case. Hopefully, we can entertain you the next 25 minutes or so.
Okay, so this is a 59-year-old man who actually went for his regular medical checkup at another hospital and had a CT scan done, CT angiography, which was abnormal and was referred for further investigation. He also had an echocardiogram that showed a good ejection fraction with inferior wall hypokinesis. Had a treadmill test done that was abnormal at stage 3. I think it's a Bruce protocol. And a thallium scan that showed a large reversible anterior defect, together with the partial reversible inferior defect. He was totally asymptomatic before this checkup. His risk factors are diabetic, dyslipidemia. He also had a father who died of a heart attack. At the same time of the CT angiogram, he also had a CT brain angiogram as well as part of his checkup. It showed a left MCA stenosis. He also had no symptom of any previous stroke or TIA. And because of all this, he had an angiogram done about a week or two ago.
Can we show that angiogram?
Yep.
So this is the old angiogram. Hopefully, you can bring it up for you.
Playing.
So you can see the on the top. Can you see the old angiogram?
Yes.
Yes.
So the sorry, Dr. Wasin.
Okay, the right coronary was totally occluded in the proximal segment with some faint bridging collateral going down. Can we go to the next picture? Probably can skip to the left coronary injection. Or perhaps we could show the.
Yeah, okay, we can just show it today because then we don't have to go back.
Okay, can we see the picture of the left coronary system from the AP cranial projection?
What we see today is on the right side.
Okay. So there's a disease in the left main, look more severe towards the distal portion, and also into the proximal LAD, and it's look like a mild disease all the way just past the first septal branch. Now, 2 weeks ago, he also had an FFR done to this left main LAD segment. His FFR resting was 0.75, and with adenosine went down to 0.55.
Okay, so I think if we look at the history, it's actually quite interesting that he's completely asymptomatic, undergoing an executive checkup. So if you look at the U.S. Appropriate use criteria, he is relatively high risk, male, 60 already almost, smoker, ex-smoker, diabetic, a family history, hypercholesterolemia. So the sort of pre-test probability is relatively high. So the question is what test we do, and obviously he's asymptomatic, so he probably end up doing nothing. But because of his checkup, he had a CT scan. So then it lead to a cascade of various things. So the question is that he being asymptomatic, should we do anything at all, or should he have bypass surgery?
Maybe I didn't hear it correctly, but didn't you say there was a reversible defect on the nuclear stress test?
Yes, but he's asymptomatic.
So symptoms no, but ischemia yes.
Yes.
Correct.
So even for the appropriate, inappropriate, that should be okay.
I mean, the first test is the question. Once you have one test, then you kind of lead to the other, right? So the first CTA test, in the US, probably most insurance company would not let you do that.
Yeah. Yeah, I think that's the point. He never would have gotten a CTA in the United States. He presents as somebody who's got, reasonably high pretest probability due to risk factors, but he's asymptomatic.
Right.
And, for a checkup.
Right.
So I don't think anybody would have done anything in the U.S.
Right. Probably lowest cholesterol, stop smoking.
They would have missed
usual.
this.
Yeah.
Distal left main, total occlusion of the right.
So the question is, what therapy should we offer him? Obviously, the right coronary is a pretty significant CTO, takes some work, pretty good territory as well. And the LAD supplies collateral to the right as well, so that's why the FFR is pretty positive, even at rest. So the question is that if we're going to do interventional therapy, we need to sort of evaluate this a little bit further. We basically perform intravascular ultrasound both in the LAD first, and then maybe show you that first, and then see, maybe can have a discussion what to do. So Dr. Khan is our IVUS interpreter. So the first thing we did is wire the LAD and put the IVUS down the LED.
Yes, it is LED pullback IVUS, and we get start from here. It is just below the big septal branch. You can see the septal branch here, and if you take a look at this septal branch, it is so big and no disease, and well open to the LAD here. Then disease started. Here is moderate plaque, but lumen is maintained more than 4 square millimeter. And you can see the echolucent eccentric plaque, but it is not so much. And it is very diffuse disease. So even though the plaque amount is not so big, it is very diffusely involved in the mid to proximal LAD. And it is near the LAD ostium, and you can see the eccentric plaque. And maybe here is the minimal lumen area side, and you can see the circumflex here. And how about the circumflex? You can see here, it is the wider shadow, and I think here to here is the circumflex. So I think the disease is not so significant, even though it is oblique view. Then you can see the polygon of confluence area, and the minimal lumen area is here. It is most the severe luminal stenosis. Then the lumen is getting larger, and you can see the concentric plaque. And you can see here, there is a plaque rupture. It's a very irregular border, so it suggests the presence of plaque rupture or plaque ulceration. And also you can see the attenuated plaque, and it suggests high vulnerability of the plaque and the high risk for the distal embolization. But the lumen is larger and larger, so at the left main ostium, the disease is only minimal. And then we check the measurement, and I will show you that. So it is just below the big septal branch, and this is maybe the landing site. The vessel size is 3.4 millimeter, and lumen size is 3.0 millimeter. Then the left LAD minimal lumen area side is here. So the lumen area was 3.5 square millimeter, and the whole, the proximal to mid LAD, the lumen area was 3.5 to 4.0 square millimeter, but it is very diffuse. And then, how about the left main? The lumen, minimal lumen area of the left main segment is 3.8 square millimeter. It may be significantly, the functionally significant. And here is the potentially, here is the proximal landing site. And you can see the vessel size more than 5.8 millimeter, and lumen size is 4.5 millimeter. And total lesion length is measured as 39 millimeter.
So when we go by the circumflex, which is sort of a trifurcation vessel, meaning that it has a short segment of circumflex and it becomes ramus or high OM, and then another, you can see it on angiogram right now. So looks like there's no disease, but just to be sure, we actually did an IVUS through the ramus branch as well. So Dr. Quang can quickly show us that particular IVUS.
Yes, it is IVUS evaluation from the RI pullback images. And you can see the minimal disease. The vessel is more than 3 millimeter, and there is no significant disease. And then its side branch. And here you can see the circumflex here, and then the LAD is coming in here. And you can see the disease. There is the echolucent plaque, but the plaque is not so large. At the ostium, and then polygon of confluence zone. So just below the frame.
Yeah, so I think the circumflex takeoff looks pretty good, and I don't think we need to worry too much about it. So we're going to treat this interventionally. I would think a crossover from left main to LAD will be the sort of the choice technique. And whether you need a wire in the circumflex at all, I think is debatable. We have a wire there for the ultrasound, so we left it there. So the question I have is for the panel to help me a little bit is, where do you want to stent? If you look at the angiogram, maybe go back to the AP cranial view. So obviously the left main needs to be covered from maybe 1/3 into the left main. And then I think as the ultrasound shows, the ostium of the LAD is quite involved, and maybe all the way down to the first septal or so. But there is enough of an area in between, you can probably land there, that can leave, get a pretty good lumen area, but you will leave a fair amount of plaque behind, obviously not covered, which is okay. But there is a chance that you run into some edge dissection, especially there's a pretty good size discrepancy between the middle and the proximal LAD. So that's one downside. Otherwise, it's just to cover the whole thing from the first septal or so all the way back into the left mains.
Yeah, I mean, if you integrate the IVUS findings with the plaque volume, and even though at one couple of points where there was minimal luminal area restriction, so maybe you should cover from good to good. So that would be my view of how doing it. Marty and the rest of the panelists?
Yeah, I agree. I mean, you could be cute and try to stop the stent before that first septal in that what appears to be normal looking or more normal looking area. But I think the angiogram in this case is deceiving.
Yeah.
The IVUS clearly shows there's a lot of diffuse disease in this LAD, and my preference would be to stent to beyond that first septal branch to the segment that looks to be more normal, closer to that small second septal branch, and bring it back literally to, if not the ostium, within a millimeter or two of the ostium of the left main. Now, to do that, you may need 2 stents in this case, obviously.
So you said it was 30, right? By IVUS, it looked
39.
like it was 30 in length.
39. So
39.
So my thought is to take a 38 3.5 and just go down and see what we have, and then see whether we can land it just beyond the large septal branch, a little indentation on angiogram.
Yep.
And then see where we reach from the left main and go from there, and then decide whether we can, need to go further, a second stent. But I think we should take a long stent and go from there.
I think that's a perfect idea.
That sounds good. All of the other point is we never disagree with your boss, right?
Yeah.
I mean, the one thing you don't want to do is if you're going to use 2 stents, you don't want to leave the stent near the origin of the trifurcation. So you want to make sure that you bring your first stent back into the left main.
Right. So if I'm going to use 2 stents, I would cover from left main whatever we want to land to whatever to LAD and put a distal one in, because I think once we put a stent, then it should be okay to just add to the edge. But hopefully we can land it one stent. The second question is that I have not pre-dilated this lesion. And I think from the ultrasound, there's not much calcification, and And I think there's a risk that if we're going to do a pre-dilatation, especially waiting, that there could be dissection and so forth. So I think I'm going to try to see whether a 38 resolute 3.5 would go down and take care of this.
Yeah, I agree. I'm not generally a fan of direct stenting, but in this case, I think I would do it for all the reasons you suggested. It's not going to be difficult to get the stent down. You're going to be able to see it well enough. I think you'll cause less disruption of the artery. I think it makes perfect sense.
And size-wise, you're going to obviously size for the LAD and then post-dilate.
Yeah, so it's 3.5, 38. And the nice thing about the Resolute, and it can go up a pretty good size to 4.5 or more. So we can probably take care of that. So in a little bit, once I get the stent down, I'll probably take the wire down out of the circumflex as well. There's no point in having the circumflex wire down there. So this one here. So I'm too far now, I think. I'm coming back a little bit. So can you give me a test? So plenty of room.
Yep. 38 would do it.
38 would do it.
Yep.
So test again. So with plenty of room on both sides. I don't think I have to take the stent all the way to the ostium because it gets pretty big in the ostium.
But it's okay, and I mean, you saw the plaque was virtually inexistent in the proximal section.
So let's go to the spider view for a check. I always just want to make sure that it's not discrepant in the two views. Okay. Test, yeah. Looks pretty good.
Yeah, I like that.
Yeah, go back to the AP cranium, and then we can get ready to inflate.
And the landing zone at the AP cranium looks pretty good at that almost second separate, right there.
Yeah, I think it's good. Agree?
Yep.
Okay, let's go ahead. Inflate.
Okay, inflating. 2, 4, 6, 8, 10, 12, 14, 16, down. 16. Yeah, because of this occluded right, I don't want to stay on too long. And these long balloon as well.
So you chose to take the wire off the circumflex because you thought it was big enough and the angle to it was good.
Yeah. So give it a little test. Just a little test. Yeah, okay. Let's inflate again. Let's go a little faster and go a little higher pressure.
So we've seen Ian
6,
do this and
8,
Alan,
10,
Marty,
12, 14.
you don't care about geographical miss when there is a sizing like this? Irritating the area. That's why I always go back to the beginning of the ostium of the left rib. I almost right or wrong.
I mean, I do it when I think I'm going to put a second stent in. But in a situation like this, yeah, and I think you're probably going to have to size up the left main anyway. So, in this case, I might not have done a second inflation. I agree with you.
Yeah, I think it's the size of it. Sorry, a second.
Yeah, you have a 5.8, it looked like, or at least 4.5.
I mean, the difference also is that, I mean, Alan had a good point with the occluded right. You don't want to leave it up very long, but generally what I would do is leave the balloon up for a full 30 seconds. In this case, depending upon blood pressure and other things, I might have gone down sooner, and then second inflation is very reasonable. You just don't get full stent expansion in a few seconds. Looks good.
Let's do a spider.
I think the location of this is perfect.
Yeah. I think it looks quite good. The 3.5, and we're going to give a little nitro. And probably, I want, just for sake, I'm just going to take a look at with an ultrasound and see how it looks like now before pre-dilatation, and then see where the area needs to do the most work and try to leave the rest alone.
Yeah. And also the good news is that trifurcation looks pretty good. There's no shift, anatomical shift to it.
From the angio, it really looks quite good, but I think doing an IVUS in these left main bifurcation give you a lot of reassurance that you don't have to worry about it. Even when you sometimes see a little sort of a white line because of the strut covering the circ, you will still be happy with it. So I think the pre-check with this this position, I think is a very helpful thing. So I'm going to put an IVUS in just to take a look at it in case we run out of time, and then we can see how, without pre-dilatation, how this looks.
It shows after you place the stent that it actually wasn't a quadrifurcation, it's actually just a bifurcation, and then there is a separate bifurcation or trifurcation after the origin of the circle.
Yeah, I think so. It's just when the IVUS is clear that they joint and then they joint the LED. Okay, so let's show IVUS. You can see it.
Okay.
Go back.
We start from the distal reference segment, and it's absolutely normal. And there is no complication like dissection or hematoma, but there is no evidences. And
a little systolic compression, almost you think there might be a little bridge there.
Yes.
So if there's a bridge, we don't want to land close to it, which is good.
It's very good landing, and it's well expanded and well opposed to the wall. And the stent area is more than 7 square millimeter. And it's the side branch and well open to the LED. And so far, the result is so good. The stent area is larger than 8 square millimeter, and we have the cutoff value at the LED ostium. It should be 6 square millimeter of the minimal stent area. And we will check that. Quite big.
So far looks pretty good. Maybe a little underdone a little bit.
Yes, it may be the ostium, LED ostium. It's obviously more than 6. Then you can see some stent strut here. Opening side, so it makes some tensor artifact, but the circumflex is normal.
Yeah.
And here is the left main stent, and it's larger than 8 square millimeter.
Yeah, you see the apposition is with that soft plaque is very good.
Yes.
Throughout circular.
Yeah. Yes, some the plaque protrusion here, but it's very minor.
Actually, it's quite good.
Yes, and the left main ostium is not covered with the stent, but as long as the plaque is minimal, there is no relationship between the clinical outcomes.
I think we landed in a pretty good spot in the left main. There's really not a whole lot of plaque there. If Dr. Khan can show that again, I think we don't have to worry too much. I'm probably just going to post-dilate a bit on the original left main distal lesion and the proximal LED, and then maybe touch up a little bit on the proximal part and be done.
Yeah, that looks very, very good.
Yeah, I think it looks excellent. I think there's very little you have to do. I think you ended approximately in the left main, right in the perfect spot.
Yeah.
And I think that there's a great distal transition in the LAD. The branches are not compromised, and I agree. Maybe, touch it with a 4.0 balloon and
call it a day.
The final minimal stent area at the left main is 9.3 square millimeter, and at the LAD ostium, it's a 9.1 square millimeter. Very big stent.
Well, I tell you, just by IVUS, if you wanted to do nothing, you could do nothing as well.
Yeah.
But it wouldn't hurt.
I wanted to ask about this, Marty. So at least I heard, and I'm not sure if that's true, that when you put a very long stent, there is somewhat inhomogeneous deployment of the stent, even though it looks good in IVUS, just because the balloon is not able to exert a stable force on that stent, and that you should post-dilate with a non-compliant balloon, even if it looks good. Do you think that's true or not?
No, I'm not impressed with that argument. I think if the IVUS looks, if the stent looks fully expanded, if it looks like it's fully opposed and it looks like it's circular, then I'm not sure what additional post-dilatation would accomplish. So
I agree. I mean, even that hypothetical is not proven to be so with this intravascular ultrasound millimeter to millimeter view.
So the resolute long stent data was presented yesterday. It was done in Asia, and Dr. Rabaya presented. Can you go ahead and inflate? It's actually, the result looks quite good. Really, the TLR is like 4% or less, depends on the set. 8, 10. 12,
so Alan, 14, we have about a minute left.
Yeah.
Is this a 4.0, Alan?
Yeah, it's a 4.0.
Yeah, great.
I'm going to dilate that. I don't see any reason to go distal. It's just going to be just that proximal LED and a little bit of left main. Go ahead.
Yeah, I
inflate.
see a reason why not to go distal, because
Yeah.
you have an excellent luminal and then you don't want to compromise
16.
the good result.
Yeah, I'm just
16.
going to try to see it, a little bit better and come back and just touch up one little bit, and then we check with the IVUS at the end, and then be done. That's good. Okay. Down.
Down,
Good.
16.
So I think this crossover technique, I think you guys heard the presentation of the cross and the perfect study, and even though that's obviously excluding left main bifurcation, but the principle I think is still sort of the same, that if you don't have to do any kissing ballooning here, it's better off, because the main vessel stent is more completely opposed, not distorted, and hopefully lead less to a TLR in the proximal or distal area. So we're going to do a final ultrasound and see how it looks like. We'll do an angio real quick. Make sure everything's okay. Ready?
So the final ultrasound, you're looking for what? Just bigger area, or?
Yeah, we want to just make the proximal LAD ostium was a little small to me, and so I just want to make sure that it's expanded well. And that's really the only area that even the proximal left main edge, I thought was okay.
Yes, that's why I was wondering
Yeah.
whether you could skip that.
Sometimes we skip it, but I think here is I have Dr. Khan with me, so give me even more confidence to look at how thing looks here. So the question is, in this person, do we need to do anything to the right coronary? And is it something that should be sort of bring back another day to open up the right, or should we check
certainly
the?
wouldn't do it
See how he does.
Yeah, certainly not
wouldn't do it
today. Yeah, of course.
I think this is an interesting discussion. It's a relatively young patient, and did by 2 tests have significant inferior ischemia. But that's a Talmudic discussion. I think you're going to have a hard time opening that antegrade. I think that the entry point was ambiguous, and it was a fair distance.
But the ischemia may abate somewhat now, because part of it was the donor artery was really compromised.
No question that you may get less ischemia, and you can't make an asymptomatic patient less symptomatic.
Right.
So,
I think that's why it also pushes me to treat the whole proximal LAD, because even if some residual lesion, sometimes in a big territory, you can still bring up an abnormal FFR. So I thought treating that all pretty much to normal, it would be helpful.
For sure.
It looks pretty good.
It looks like here, if this is the ostium of the LAD, it looks even bigger.
It's bigger.
yeah, no, this looks terrific. This is a great case.
Yes, it looks like at least more than 10 square millimeter, and I will measure. And opposition and expansion are so good. And then you can see the circumflex that is coming into the left main, and some stroke here, but well open. And it is the POC distal left main side, but it is larger than 10 square millimeter. And
It's really quite round and nice in the proximal left main there.
Yes.
Couldn't be better. Looks terrific.
Looks good.
Yes. And
as we see this IVUS evolving, it's going to be about 30 seconds.
Good.
So
yep. All done. Yep.
It looks fantastic. Congratulations. Well done.
Thank you. And I think this is really quite interesting in terms of looking at even criteria for doing anything. It is really kind of eye-opening. I'd like to thank the team, Dr. John, Dr. Patari. Thank you very much, and thank you for the help and the hints that you gave me today. Thank you.